but I'm sure that we're all seeing that our patients are becoming quite poorly with the cold weather. So we're really obviously quite busy all ourselves as well. We've got the agenda up there today. For today, we've got a few things that we're going to get through, and I'm going to do my best to keep to the time. So first of all, we've got Dr. Sen, who's just got a few notices that he's going to give us.
Right.
Dr. Sen?
Yeah, thank you everyone for joining. You know, the December month is a very traumatic for us because this is the month where we lose people, which is as usual. But I just wanted to tell that we have lost two of our colleagues. One is Dr. Chalabi, all of us knows. Dr. Chalabi was buried this week at Iraq, and we wanted to do a memorial service today, but the doctor will come back late this evening. So she said if she can participate in memorial probably in January. So we have another sad story about Dr. Momin, who was a founding GP of Greenwood Medical Center. He also passed away. And Dr. Gopinathan is away. He just left the country this morning. So he spoke to me yesterday, and he also said that he will also run a memorial service for Dr. Momin next in January meeting. So I just want everybody to be healthy. I would ask everybody to join in January to remember our. Thank you.
Aparna, should I just chip in to say there wasn't anything further? We just obviously wanted to share that difficult news and to advise people that if they wanted to make any contribution in terms of thoughts, we would like to have a bit of time in January's meeting.
Thanks, Karen. And I'm just going to take this opportunity to remind everybody here that I know that, you know, aging is inevitable, but our health problems can be looked after. So if you've not had your NHS health check, or if you're due a checkup, you know, I think we need to put our own health first, because I think we're so busy with work looking after our patients, we sometimes don't necessarily take that care of ourselves. So please, everyone, go and get your checkup, or if something's due, you know, please book an appointment with your GP. All right, so the next item on the agenda is we've got Adrian Meredith here, who's going to be discussing the RCGP veteran-friendly accreditation project. Now, I didn't realise we've actually got quite a lot of veterans within our Newham residents. There's quite significant numbers, so I'm quite keen to hear what Adrian's going to be talking about. Adrian, over to you.
Thank you very much for having me. Adi Meredith, retired military medic and regional lead for London and the South East for the RCGP Armed Forces Veteran Friendly Accreditation Programme. So the Veteran Friendly Accreditation Programme is a quick to implement free support programme for GP practices in England that will enable the practice team to easily identify, codify, understand and support veterans, and where appropriate, refer them to specialist healthcare services that have been specifically designed for them. So, in the recent past, NHS England recognised that they must act to better serve the veterans living amongst the general population, leading them to articulate this text lifted directly from the NHS long-term plan, where they stated they would expand their services and further by 23-24 look to the RCGP to produce a package that would assist practices in accessing those services. So they invested heavily in bespoke referral pathways, both clinical and social. I'll talk a little bit more about those pathways in a few minutes, to meet the specific needs of this cohort, and then further commission the RCGP to produce this package that best supports practices, understanding the specific needs of veterans, enabling them to utilise those pathways. Next slide, please. So, Why are veterans treated as a special group? Well, it's a very unique occupation. It's also the best job in the world, serving in the armed forces. Personnel, we ask service personnel when they join the service to relinquish many of their civil liberties. They put themselves in harm's way to protect others, and there's significant risk of injury in the pursuance of their duty. Whilst that's not necessarily unique amongst professions, the circumstances in which injury occurs and the mechanisms of those injuries certainly are very different to the mainstream. Personnel are highly mobile. There are periods of separation from the family and periods of separation of the family from their natural support network. So, as an example, I served in the Royal Army Medical Corps for 37 years, and I moved location 21 times during my military career. I moved my family 8 times and left them at home for periods of 6 months and above 12 times whilst I served on operations. Veterans there are patterns of tobacco misuse or significant use of tobacco and alcohol misuse. They drink and they smoke a lot. And there are high levels of physical activity, which causes significant wear and tear on the body. There's also transition to consider for the veteran. The occupational RAP, which is the military management ethos that envelops a service person from the moment they join, influences them to think about others before themselves. Everyone shares the same values, everyone moves in the same direction. They're fully supported throughout their careers by the service, and all their human needs, and thinking Maslow from a human needs point of view, are met by the organisation, and there's an occupational health service that's second to none. On transition, all of that stops. So an individual is fully supported for the period of their service, and in the moment they leave, all of that stops. The outcome of their service, the majority of veterans are more likely to suffer long-term illness, disability, or infirmity. And it's 52% of the veteran population compared to 35% of the general population. There's also an elevated risk of PTSD, specifically in those that served in recent conflicts in Iraq and Afghanistan, and other common mental health disorders, substance abuse, alcohol abuse as well. And as we understand the well-rehearsed link between physical and mental health, and that 30% of those who suffer from long-term physical illness are likely to suffer from some form of mental illness, we can start to see why a relatively small section of the practice population merits greater consideration. Next slide, please. So, how many veterans are there out there? Well, as a whole, in the UK, there's around 2.5 million veterans. About 1.75 million veterans in England. Most of them are aged over 75, and most of them are male, though that demographic is changing circa 2000 onwards with a significant increase in female recruiting. Around 17,000 people leave the service annually. 2,500 leave on medical grounds, and the most common causes for that are mental health, hearing loss, and MSK injuries. About 750,000 of the workforce in England and Wales are veterans, and about 5.5 million of the general population are either veterans, spouses, partners, widows, or dependent children of veterans. Next slide, please. So this is bringing it home to Newham and that area. Although the average percentage of veterans in Newham is 1% of the total population, that gives around 5,000 veterans living in Newham and around 11,000 veterans and their families. That percentage is variable. In some areas there are peaks, and some areas there are troughs in those numbers. But there's still a large amount of veterans in the area, and I've broken that down by PCN for people to view in the slide deck at a later time to sort of capture how many people there are or could be in those areas. Those figures are taken from ONS figures of those people that declared as a veteran on the 2021 annual census. So they don't account for people that didn't see themselves as a veteran or reservists. And reservists who aren't on mobilised service are classified as veterans. So the numbers we've estimated there are likely to be low. Oh, just go back. Okay, sorry. I think I may not have given you a slide. There are, I mentioned earlier about the bespoke referral pathways that are on offer, that have been invested in by the NHS, and there are 5 of those. 2 of those are clinical, 3 are social. Op Courage, for those people that aren't aware of Op Courage, is a national strategy with a regional footprint. Op Courage is the Veterans Mental Health and Wellbeing Service. It encompasses the 3 prior veterans mental health services and brought them under one banner. All these pathways have got new names. They've all got an operational name, and that's principally because from feedback from veterans and their families, they understood a pathway better or a service better if it had the word op in front of it. It's not intended to militarize those pathways. But Op Courage, go back to Op Courage. Mental health and wellbeing service available to all veterans and their families in London. That's immediate families, those families living with them. Significant advantages of Op Courage is that they are veterans aware and understand what a veteran has been through, and the referral pipelines are ahead of that available to the generic population at the moment. Referral to assessment for a urgent case is within 5 days at the moment, and within 10 days for a routine case. Slightly ahead of the generic pipeline for the NHS for urgent, but significantly ahead for the routine. Op Restore is the veterans physical health and wellbeing pathway. Again, it's a national initiative with various regional centres. It doesn't seek to reduce the pipeline or reduce the sort of referral time for any individual. However, it does adopt a wait well approach, and it's available to any service person who was injured or has a physical issue that was caused by or is related to their service. The wait well approach is all about, once a referral has been sent from a GP to the service, it's been accepted, there's a swift identity check to ensure that the individual was indeed a veteran. But once it's been accepted, then a Defence Medical Health or Defence Medical Welfare worker is allocated as a social prescriber that will reach out to the veteran in the first instance to see if there are any social prescribing needs ahead of the first referral or the first assessment. And those social prescribing needs can start and then be part of the holistic treatment plan at the end of the day. Op Community is a network of public sector and third sector organisations that are specifically positioned to help and support service personnel, veterans and their families. The regional Op Community for London is based in North Central London, ICB, but it's there for social prescribers to understand and utilise the services. Op Nova is a network of support for those veterans in the criminal justice system, and Op Fortitude is a government scheme to end homelessness for veterans and their families, and has a specific hotline to ensure that no veteran or their families will ever spend a night on the streets. So those last 3 are very useful for the social prescribers out in practice. Next slide, please. Oh, you've dropped one. So the package itself and what it means to a practice. What do we ask of a practice? So first, and I suppose most importantly, we ask each practice to apply. We want you all to apply. Please apply. It takes less than 20 minutes and it will definitely make a difference. Not just me that recommends it. NHS England and North East London ICB thinks it is the single most effective way you can improve the health of a veteran amongst your practice populations is to accredit as a veterans friendly practice. We'd also ask the practice to commit to identifying and codifying veterans amongst their practice populations. And we ask that the practice nominates a clinical lead to act as a focal point within the practice. Does not have to be a GP. Just a respected member of the clinical team, somebody that everyone would listen to. But that individual is the focal point and lead within the practice. What do we give to the practice? Well, once the practice is applied and the clinical lead has been nominated and the application's been accepted, the practice becomes accredited. We'll furnish the said lead with a veterans awareness package. The whole package, if it's sort of consumed in one go, takes about 2 hours to consume. It starts with a 24-minute YouTube presentation about the programme, and it's delivered by the programme lead, assisted by GPs that have gone through the process. The lead will then be introduced to the other areas of the package, such as an NHS Armed Forces update, a draft patient's charter, top tips, newsletters, posters for front of house, etc. And there'll also be further online training to equip them for their role. All this information equips the clinical lead to be able to deliver a short 30-minute PowerPoint presentation to the practice on what accreditation means to that practice. As I said, there's also information about subsequent training available for the clinical lead that can be done as CPD, and it's hosted on the NHS e-learning portal. In fact, that can be done by any clinical member of staff should they wish to undertake it. There are 3 sets. The first part is about NHS healthcare for the armed forces. 2 hours of sort of training broken down into 20-minute slots. The second set is a presentation on the health needs for military veterans, 45-minute film presentation. And the final block is a RCGP e-learning site piece on military veterans, which takes 15 minutes. I would advise the RCGP one first. We'll also commit to keeping the practice informed of any future developments that may be to those 5 bespoke referral pathways, and be on hand if the practice has any questions or concerns, or any ideas that we may improve the package. And finally, why is it important to both patient and practice? Well, it's important to the patient because they can feel that the agency they look to for help. So the agency they look to for help actually understands them. Research shows that veterans are reluctant to engage with services who they feel won't understand them, which leads to significant delays in their treatment. And from a practice point of view, it's important to the practice because it is, and it also highlights to any external inspecting organisation, good healthcare governance. It's ensuring the right person is referred to the right clinical professional at the right time, so to hopefully ensure the best possible healthcare outcomes. Next slide, please. So that's the final slide. I've put on there the links to the various clinical pathways, should anyone wish to explore them, and a couple of extra links. The bottom link is to the Veterans Healthcare Toolkit on the RCGP website that contains the application form for accreditation. And the third bullet is a 40-minute presentation that covers the various frequently asked questions that practices may have about the process and any benefits of the process that they may have. And if there are any questions, I could take them now if you want.
Thanks so much, Adrian. That was actually really informative. Does anybody have any questions? No, I think you were very comprehensive in your slides. Can I ask, is there any practice? You know, you mentioned some of the practices that are that have already accredited. Is there anybody from any practice here that wants to just share how it's helped them and helped any patients that may be veterans? Let me see which. So anybody from Tollgate or Stratford, Liberty Bridge? Oh, Anil.
Hi, everybody. Just
Hi.
so yeah, we've got 3 practices in our PCN accredited already, and we're looking to do all 5. We have done a bit of work. We've done the training, and everyone's trained up in terms of admin, clinical staff, and it's been a fairly seamless approach. Just worried about the numbers, though. From our PCN of 40,000 patients, we've only identified 7 veterans as such coded on our EMIS system. So it just shows that potentially, looking at this slide, there's lots of veterans out there, but we don't have that information. So maybe it's just a bigger piece of work that needs to be done across the borough to just tell people that are veterans to come and let us know as well as us trying to identify them within the practice, so we make sure that we are giving them that special attention that they deserve.
I suppose it's kind of like when we have new patients registering, we ask them, are you a carer? So I think we need to emphasize, are you a veteran? And so that we can pick up patients like that, or just do it opportunistically as well.
Yeah, no, it makes more sense.
Can I just say on that, on the GMS1 form for patient registration, there is a element there, or a passage there, where people are asked if they previously served.
Oh, okay.
Although it's not necessarily read or highlighted to people, but those practices that operate a online registration opportunity, the online form doesn't necessarily always ask if they're. So it's a question to ask in registration, but there's a part of the package that comes through is advice on how to capture and identify those veterans within practice populations, and it talks about things like having a sign asking people in the waiting room, asking people to identify to a member of staff if they feel comfortable, or asking people as they present to a new appointment if they're not necessarily identified as a veteran, and other mechanisms of doing so. It's a really good quick project for a trainee or an individual to sort of look at through continuous audits, recognizing where you are on day one, and then continuously improving, finding new numbers and personnel therein. The patient participation group's great for identify people from there, just allowing it to be understood that the practice is registered, and therefore given an opportunity for someone to touch base with someone and say, I was a veteran, or I'm a veteran.
Thanks, Adrian. Tammy?
Thanks, Adrian. Really, really interesting to hear. I just wanted to talk a little bit about the Op Restore bit. Obviously with the waiting list and initiatives that various trusts are sort of trying to implement. How are you making sure that veterans are identified on that waiting list, that maybe for outpatient appointments and things like that, so that, as primary care, we can be supportive, so that we're not sort of necessarily looking always at the same cohort, that it's collaborative rather than duplication?
Well, realistically, it everything hinges on primary care codifying veterans as, or individuals as a veteran, or from an Op Restore point of view, if an individual has to be referred by the GP to get into Op Restore. They then have effectively an identity check once they're referred to confirm they are a veteran, and then they sort of move along that pathway from there. If they're not codified as a veteran, it's very easy to fall through the cracks, and therefore there is still a priority referral scheme for veterans to all services for injuries or illnesses attributable to their service, although it's not a guarantee. There is that priority service available, but if they're not identified as a veteran, it's very unlikely that they'll be plugged into that. So the key really is identification, codification, and then moving forward.
Yes, I suppose the reminders for practices are that we could ask if we were sending a referral in. That would be another opportunity to potentially identify someone who's a veteran. Thank you for that.
Yeah, maybe opportunity where a patient speaks to somebody is an opportunity to find out if they were a veteran. Oh.
Thanks, Papu.
Thank you, Afana. Thank you very much for your presentation, and very grateful for your service. I just want to ask, is that I know we can't get an answer here. In some countries, the government provides private cover or high-level medical cover for served veterans or current personnels. So, why we don't have it here? Secondly, people who have private resources, they get appointments the next day or 2 days later, 3 days later, and why are veterans not given that opportunity to go private? Is there something that we are missing in this country? Thank you.
Yes. Well, sorry, there isn't another service for veterans outside of what is available through the NHS. There are for serving personnel, and there are various sort of referral pathways and opportunities for those still serving. But unfortunately, when they're discharged, when they become a veteran, there's little outside the referral pathways we've discussed today.
Thank you. So is there a sort of database that you could share probably to identify those veterans easily within the borough? Because obviously, you know, mobility is huge in Newham. Within practices also within and outside the borough as well. Is there any database that you could share that we could tap into or something? Thank you.
There isn't a database for it because at the moment, all veteran data, the fact that individual served, is the property of defence, and for various very good reasons that information isn't released. So all we have are is the ONS figures of those people that identified as a veteran, and although we don't have their names and contact details, as it were, we can find out using the OS data by postcode how many individuals within that postcode identified as a veteran, shown as a percentage of the population.
Thank you very much.
And I can forward the link to that through if you wish. That allows even at practice level people to get a feel for what they're aiming for when they're looking to capture and codify veterans within their populations. That it should be somewhere around that figure.
Thanks, Adrian. If you could share that, that would be useful.
I can indeed.
Thanks. Any more questions for Adrian? No? Okay. Thanks, Adrian, for taking the time to share this with us. And
Thanks very
hopefully we'll have some more practices on board in due course.
So thank you very much.
Thanks. Bye.
Bye.
Right. So the next item on the agenda is Newham Rise. So we've got Valentina here, who's the Deputy Service Manager. I think all of us would have seen an increase in our patients seeking help, or maybe not so much seeking help for any addiction problem. So I think it's good to have an update from you, Valentina.
Hi everyone. I have a bit of a presentation. Should I share it myself or? Oh, you got it. Perfect. Okay, so if you could go, further up. And the next one, please. Okay, so hi everyone. My name is Valentina. I'm again the Deputy Services Manager for CGL Newham Rise. It would be nice to know with a show of hands, I don't really know how you do it on Teams. I guess you can just raise your hands. How many of you know about our service? Okay. Good, 7 people. Amazing. Okay, so I'm really glad that I'm here today. Just to make sure that the whole of you, by the end of the next 15 minutes, are very fully aware of who we are, what we do, how to refer to us, and what for. So CGL Newham Rise is the only service in Newham that has been commissioned to work with residents of all ages in the borough that struggle with drug and alcohol misuse. So the service is rather big. We have 3 hubs across the borough, one in Stratford, one in Canning Town, and one in Manor Park, just on the border with Ilford on Romford Road. Each hub is a fully equipped team, basic team to kind of deal with assessments, psychosocial intervention, clinical intervention, and kind of it's working the service user then towards a discharge pathway. So we have a number of teams, as you can see, some of which are divided by the substance of choice for the service users. So we obviously have a alcohol team, an opiate team for those residents that may struggle with prescribed or illicit opiate-based substances. We have a non-opiate team for anyone that is struggling with everything but opiate-based substances. We also have an outreach team which works in coordination with our integrated blood sleeper service, which is also CGL service, and works predominantly with rough sleepers in the borough or people with no recourse to public fundings. We have a children and young people team. So we work with children and young people from the age of 11 to the age of 18. And then we have a transitional worker that kind of picks them up from the age of 18 to 25. And so the kind of pathway for children and young people, should there be the needs, can kind of be kept within the same service. We then have a criminal justice team, which is kind of devolves its efforts solely to the continuation of care of those residents that might have been, kind of released from prison into the borough. We have, again, a rough sleepers team, as I was saying, who works alongside the outreach and engagement team. We also work in partnership with our colleagues at IPS. So they are a NDTMS and found service which is co-located in our hubs to make sure that all our service users and Newham residents that are struggling with substance misuse get given an opportunity to find employment in a way that is targeted to the specific needs and support. So those that are receiving prescriptions, for instance, for alcohol-based clinical support or opiate-based clinical support, they can still avail of the team at IPS to sort of find employments that sort of responds to their specific needs. If you can move to the next one. Right, we have a rather wide offer. So one thing that I really want to stress with you here is a common misconception is that drug and alcohol services like ours work solely with service users or residents that are currently struggling with substance use. That's not the case. That is not correct. We work with anyone that has in the past, is currently in the present, and would like to avoid in the future struggle with any alcohol or substance use. We work with people and residents that are struggling with illicit substances, but we also work with residents that are struggling with licit substances, i.e. prescribed medications. The service that we offer throughout this array of possible circumstances go between structured activities and group offer or one-to-ones, clinical support. So we have a team of nurses and prescribers and non-medical prescribers that can support the clients through the detoxification program and also through the stabilization program. So we will look at the clients from the moment they come in with titrating them into opioid substitute treatment to the moment they are drug-free. Either they are in the circumstances whereby being permitted to attend to the detox in the community, so within our service, or should they be referred to a rehabilitation program and detoxification program. Yeah, so we're looking after their appeal to public funding and kind of literally hold their hands until they are accepted in detox. We have a health and well-being focused support around the clock. So our nurses provide BBVs, EPSI, checks and controls. We provide home minimization support, which looks into of course, the sexual health and the substance misuse kind of side of things. So we provide naloxone, which is life-saving drug for those misusing opiate specific substances. We also work with our legal advice, it's called Release, and they present once a week. So our service user will receive support by release or be signposted to those that can support with any issue, depending on the personal circumstances. So they can be housing issues, can be debt issues, can be financial issues. You know, it can be that they don't have recourse to public funding and would like to do something about it, and that's kind of working towards assessing that. We also have an in-house family and carers service. So for those that are loved ones or caring for someone that is misusing substances, and we accept referral for the family and carers, even though the loved ones are not necessarily our clients already. So that we get external referrals for mothers, fathers, friends, and you know, and carers of those that are in active addiction. We also provide a number of trainings and workshops for professionals and not. So we are happy to provide training for schools and you know, service users for other services, but also we provide training and upskilling workshops for staff that would like to know a little bit more about drug and alcohol and would like to be able to work in a basic way with their clients or their patients that are struggling with substance misuse. We also have a in-house peer mentoring support scheme. So the idea for it is that our service user would join the service if they need support, and also once you know they've kind of come to the other hand, then in a place now to release themselves from the health and support CGL Newham Rise, they can volunteer for us either with lived experience as a lived experience volunteer, such as peer mentors, or as a overall volunteer. So we have training programs, and we have possibility for them to join external resources to kind of help them and support them building up their confidence and competency to perhaps apply for a position with our service or with anyone else externally that they want to. And yeah. So this is the specific children and young people offer. So we work with children and young people, as I said, 11 to 18. We have two specific offers for this. One's been the resilience working offer, which substantially works with those that are in active substance misuse. So any young person themselves who is using vapes, for instance, even that being not THC-based vapes, but normal, not normal, kind of cigarette-based, nicotine-based vapes, or illicit substances. Additionally, we have a hidden harm offer, working with children of all ages, as young as 11, that have been brought up in families where there was substance misuse, therefore carrying secondhand trauma. If you can move forward from that, we also thank you. The team covers a universal kind of service offer, which is focused on, again, upskilling schools, staff, and students in school around the dangers and kind of cultures of substance use. So we are often present at school with workshops, with group work, and assemblies. Can you move to the next one, please? Thank you. Our family and carers team offer advice and guidance. Family and carers support groups, which is either peer-led, so led by the family and carers that kind of gone through the process, or led by a professional. We offer monthly workshops and on drug and alcohol awareness, specific substances. So very often the service users that are in very complex active addiction may be working towards detoxification, are living at home with their wives and their families and their children. So the family and carers offer is very supportive to the needs for those that are looking after our most vulnerable service users, to know exactly what expects them, to know how to look after them in the right way, and to kind of promote resilience. This is not necessarily a straightforward road, the one of recovery. So it's not, and it doesn't just involve the person that is seeking that recovery, but also everyone that is walking across it with them. Our family and carers offer 3 different pathways. So one is the universal intervention with assessments and signposting. And then we have the group pathway with support groups and workshops. There's 2 of these, one is online and one is face-to-face. Additionally, we have 4 brief one-to-one sessions for those family and carers that may have may need a little bit more support from the specialist, and we have a combination of the 2 in case one or the other is not enough. The Strengthening Families Together, it's a group work program that we have acquired together with the children and young people team. So we're looking at the family in its entirety, as well as the service, looking after the person struggling with substance misuse, their families and their children. The Strengthening Family Together program kind of brings them all together. At a certain point of the services users recovery journey, and once the family and carers have acquired that level of resilience and knowledge to be able to conduct certain conversations and kind of come up with arrangements. Our harmonization program is quite wide, so we realized that the best way to support current generation and younger generation in protecting themselves from illicit substance use is to equip them with an understanding of how to do it in a way that will hurt them the most. So our service has focused quite a lot on this. Sorry, one second. Our service focus quite a lot on this, and we have a harmonization program specific for each aspect of the service, for our family and cares, for our CYP, for our alcohol team, non-opiate team, and opiate team, and our outreach and engagement team, so that for each services presenting with their personal needs, that there's a tailored harm reduction offer built around. We also have conduct trainings for professionals on naloxone, drug and alcohol awareness, chemsex, hidden harm, and family and carers specific one. Everything is on our website for you to have a look at in case you are, interested in upskilling your team or your colleagues, and I'll be happy to, I'll be happy to facilitate that. You can go on the next one. Right, so this is, I will send you the, I suppose I or someone else in the team will be sending you this presentation with our link to referrals. I know that a lot of you, 7 of you in fact, were already aware of Change Relief, Newham Rise. For those that aren't, please be aware that referrals must be sent through our website, and information, our referrals must be completed fully, so that we can ensure our success and chance in outreaching the clients that you're worried about, the patients that you're worried for, and therefore referring to us. Without the right level of information, we may never be able to outreach those clients, and the referrals won't really lead to any positive outcome. Same reason as to why, if you are advising someone to present to our service, please complete a referral. So we are on the Joy app, and hopefully also be on EMIS as well. Our referral, it's online on our website, and it's rather straightforward. It takes about 2 or 3 minutes. One second. Not a self-referral. No, I mean it is. If the residents want to get support and they go online and they find our website and they want to refer themselves, of course they can. But as professionals, I think we have duty of care. If a patient comes to your appointment and mentions that struggling from substance misuse, or their family mentioned that one of their loved one is struggling with substance misuse, it's always advisable for yourself to make that referral, because we can't rely on the patient's commitment of changing their behavior and improving their lifestyle in a continuous basis. They pick of commitments in stop using substances may be very, very high the moment they're talking to you, and then go down to zero literally an hour later when they're going out there and use again. So it's always advisable to kind of promote the engagement of those service users with a straightforward referral via our website. The website referral page caters for children and young people and adults, caters for self-referrals and referrals made by professionals. So I really advise you and advocate for you to make those referrals. That's the only way we have to engage with that service user, because we will then have all the information that we need: the phone number, the email address, their consent, their home address, and we can actually outreach them following their choice and decision to engage with the service. Any questions?
I have one question, Valentina. You know, the referral forms, that I've actually just opened up the link.
Yeah.
And the referral form, how at the end of the form, are you able to download something so that you can save it into the patient record?
Interesting. I'm going to have to get back to you on that one.
So that was just one thing. And then the second thing, I think my colleague that's asking about whether this was a self-referral service before, I think each clinician that's seeing a patient would have to look at the commitment of the patient. I agree. But I think that sometimes we refer patients again and again and again. And if they're not willing to engage with the service, it is clinicians' wasted time, or, admin's wasted time. So I think I agree that, where a patient is willing to engage, that we should encourage them to do the referral themselves or do it for them. But there will be a lot of patients that are not wanting or not ready at that time to engage.
Yeah.
So it's a case by case approach, I think.
Let me get back to you on this one. So right now, absolutely, I agree with you. The amount of service users that we have turning up to our service over and over and over across the years, reaching that peak of commitment, that decision-making moment where, yes, I'm ready now, today I'm going to give up using, and then perhaps dropping out 2 weeks later. And this is something that we as a service manage and make very much our focus to manage and motivate their intentions and motivate their commitment and engagement. When the patient comes to you, or the patient comes to any other professionals because they in that moment have decided or wish even just to look after their options, look through their options to stop using, I think it's imperative that we as professionals pick up that moment and kind of say that the referral form ensures that we have enough information then to continue trying to engage that service user across the space of a month, for instance. So they might not come in straight away, but if we have the referral, i.e. Dr. so-and-so referred John Doe, who lives at this place and has given consent to be outreached at home, we can send a member of staff to their home to carry out that assessment. So we are extremely focused on making sure that every single person in Newham that has substance misuse issues or doesn't yet have, but is worried that they may, or has had in the past and it doesn't want to relapse again and to kind of get back into the habit, is given support. And it starts with yourselves.
Yeah, no, I agree.
Without that referral form, we can't do anything. And service users very often don't have the skills or the commitment or the understanding of going online and self-refer themselves. That's just something that doesn't happen very often. We get very, very little number of self-referrals. 95% of our referrals are provided by other services, other professionals.
Okay, right. Dr. Lieber?
Hi. Valentina, great. My name is Vern. I'm a GP here, Ponton Dock. Couple of questions. People with the mental health crisis needing to see a psychologist or a psychiatrist is always a struggle. And how do we balance? Because usually the secondary care colleagues don't like to see people who are currently using. And then, so do you have anyone on site, like a psychiatrist, or do you have access to a psychiatrist supporting people?
Yes, our prescriber is a doctor in psychiatry. So his name is Dr. Boulos Tadros, and we also have a co-located mental health specialist key worker that is based at CAMS. No, sorry, Elft. Sorry, completely switched them both.
That's great. So with so I could refer. How quickly? So what's your turnover for referral? So if I were to refer someone,
we are contracted to respond to that referral and to make contact with service user within 12 hours of the referral being received. So it's very immediate.
Oh, that's great. I didn't know that. That's very good.
Yeah, that's what we commissioned for. So when it comes to mental health, obviously there's always the dual diagnosis kind of pathway, which is shared with our mental health partners, and we are putting things in place. We have actually worked quite a lot on our relationships with the health team and talking therapist teams. So they run co-produced and co-led groups in-house with us, with ourselves, and we also work alongside each other for those service users that suffers from dual diagnosis.
Yeah, that's really great. I'd also just comment on the things that have been said previously with shared care. So I'm a member of the London's substance use London Joint Working Group for Substance Use and Hepatitis C. We've conducted an audit as part of this in our network. And then we've managed to successfully refer patients to hepatitis C treatment, and that was with regular sort of contact with the operational delivery network nurses and the peer supporters who eventually managed to reach out to our patients on multiple occasions. So I think 3 of the 4 people we identified as not being untreated managed to do so. So in the meantime, so I think that's really good. So there's a lot of things that GP can do if we manage to work together. Yeah?
Yes.
So, and that kind of leads me to my question really is, a common question that comes up, how we can communicate better. And then, there is, I have, commonly I have patients I'm not aware of being on replacement therapy, or and so things like that. And then how do you I mean, what is your policy? Do you write to us, or do you need patients' permission to write to us? Do you recommend people to register with us?
Right. So yes, absolutely. No, that's all right. So we cannot work clinically with a patient unless they're registered to a GP. So we would facilitate that registration. We write to yourself, we write to the GPs every single time we receive we work with a service user that needs clinical work, clinical support. So before arranging our OST assessments or before arranging a nurse's alcohol assessment, we liaise with the existing GP to receive summary care records, just to be able to work with our patients in a safe modality. Every time we conduct any clinical interventions, the GP is updated on it via letter by our prescribers. And also every time that patient is discharged, we communicate to the GP that the service user and their patient is being discharged, either because they successfully completed their process and they're completely drug-free, or because they dropped out. So the GP are being kept in contact, they're being communicated with regularly at each pivotal moment of the service users' journey with us. We are also hiring because of the issues that we've seen lately. In the last 2 years, the referrals from GP and social prescriber has dropped so massively that we have recognized the need to hire a new position, that we've made that positive for specifically to try and kind of ameliorate our relationship with the primary care network as a GP outreach lead. So we're just about to appoint the successful candidate for it. So very, very soon, hopefully by the second half of January, we will have a person which will be liaising directly with the primary care network in Newham.
Brilliant. Thank you.
Any
Thanks
other
so much.
question?
Tammy, did you have a question?
Valentina answered it with what you were going to do with to improve the engagement. So thank you.
Okay, thanks so much,
Yeah.
Valentina.
So we will,
Thanks for
obviously
sharing that info with us.
you're perfectly fine. We'll do all of this, but again, I can't stress this enough in the importance of yourself referring directly to us, and for the social prescribers to do the same, because we know that they've been signposting, but the clients are not coming to us. So that's obviously not enough to ensure engagement.
Okay, great. Thanks so much, Valentina.
Okay, you're welcome.
Right, so Tammy, you're the next person on the agenda. Tammy's here with Sarah. So over to you, Tammy.
Okay, so the first thing I'm going to say is I'm here with Kate. So just a bit of a typo there. And yes, thank you very much for the presentations today. And I just wanted us to touch base because it's been a little while. And I think there's been a lot going on in the background, but we haven't had very much to update you about. So rather than just kind of saying we're still working on it, we're still working on it, we felt that it was just important to maybe just periodically step in. For me, I think I found it really helpful to go to the England LMC conference that was held on the 23rd and 24th of November. And I think in light of how we started today, and it's really important for us to pick up on that well-being. We've spoken about it before, and it not just being that sort of lip service. But I think Katie opened conference, and I think some of the most powerful statement for me, or the most powerful statement for me, was about the fact that as trusts, they are very good at knowing the speed at which to run their hamster wheel, and that like trusts, we need to take control of the speed of our own hamster wheels, and we need to provide a safe number of appointments when you can, with the resource that you have, as safely as possible. And that taking into consideration, we're all patients as well as clinicians, and I think somewhere along the way that that message very much gets missed. And so I really wanted to bring that very important bit of work back, and I think that what came out of conference is very much around the fact that we are the David in the story here, and we're constantly fighting Goliath, but actually it's for us to hold as LMC ICB to account to make sure that as David we're not missing out, and that we are extremely innovative and effective in what we do, but actually we need to be resourced appropriately and for our expertise to be valued. And obviously that won't happen if we haven't got a seat at the table. So my other point here is that I think there are lots of meetings that are being proposed, lots of joint planning groups or other groups that are being sort of proposed. And I think it's really important that if at any of those meetings you feel that you are being asked to represent GPs, and sometimes even with me in my clinical lead role, it's really hard to sort of as my diabetes clinical lead role to say, actually, is that sort of appropriate for your, the everyday general practice? And I think that that's where the value of our LMC colleagues come in, and to really utilise that resource. And I think rather than looking at us as a block, that actually we are here to facilitate, but also to be that critical friend, and to make sure that we have all the information that we need to make those decisions. So it isn't about us dragging our feet over contracts. We're really good at responding, and we've had so many flown at us over the last few months But what we haven't had is a response back and a decision about next steps. And so it's really important to understand that, you know, that isn't anything on our part per se. We, you know, obviously it does take time, but I think we're very much in a holding space at the moment as the ICB, sort of building itself. We appreciate all of that, but I think it's really important to understand that there are, really important conversations that are going on, and that, reach out to us as LMC if you need to. And I think the other thing really is that we have this opportunity for the unified voice. We don't get the best attendance, and I do appreciate the first Tuesday of the month that sort of 5 o'clock might not be the best time for everybody. But if you can still pop in, that'd be great. The links in all of the chats, still work, and that does get disseminated. The next meeting we may not go ahead on the 2nd of January, depending on annual leave, but certainly the one on the 6th of February will. So please do put that date in your diary. And I think if there are issues, and we had a really good discussion at our last meeting, and we really want to hear your voices. And I think that's important for Kate to take when she's having conversations with the ICB. So I'm just going to pause there and hand over to Kate and let her kind of, I think it's really important that we get to know her, and she is a wonderful friend and a really valuable resource for us to have. And I do very much appreciate the really heavy workload. So thank you for coming, Kate.
Sure, lovely introduction. Don't build me up too much though. Hi everybody. I'm very pleased to see that I do recognise lots of names actually on the attendance list. So hello to everybody that I've already met, and to those that I haven't, hi, I am relatively new, so I'm about 4.5, 5 months in now to my role at London wide LMCs. My background is actually in commissioning, so I feel as though I should always apologise for that. But it is working within NHS commissioning, predominantly primary care services and general practice in particular over the last 10-11 years prior to me joining London wide. So Tammy's really summarised some of the key things that I was going to mention really. So the biggest priorities that we are focusing on at the moment, firstly, is the primary and secondary care interface. There are so many, the overwhelming number of challenges that we've got that are impacting everybody's day-to-day workloads within general practice, around the communications, the pathways and the interfaces between primary and secondary care providers. Even if we could fix 10% of that, it would make everybody's working life slightly more tolerable. So that is something that we are focusing on. There is oversight of that primary and secondary care interface kind of creation or development across North East London that we are involved with. But it has been made very clear, certainly at the last clinical advisory group that I attended, which is the oversight group, that actually the work and the meaningful work around that interface group will happen at place and borough level. So I know that there was a meeting, I think yesterday, wasn't there, Tammy, with Barts, around trying to build upon the existing interfaces and interactions between providers, but general practice in the trust. But fundamentally, there is a requirement now of ICBs to actually support that work and try and get some traction on some of the things that need to be improved. So we are working upon that and really pushing for those interfaces to be created and developed, so we can start to see some movement on that. In terms of, and Tammy's already very eloquently covered it, the amount of work that is going into trying to negotiate locally commissioned contracts, including incorporated SNSs for next financial year, is immense. There is a great number of contracts that have been proposed in terms of changes or new contracts, all of which require quite a lot of detailed conversation to ensure that we really are understanding every single element of what is proposed to make sure that it is right for practices and the best it can possibly be, given the current confines, especially financially within the ICB. So that is taking up an awful lot of all of our time within the LMC, attending lots of different meetings, having conversations outside and in between those meetings to try and get us to the best possible place for April. So that work will continue, I am sure, but I'm reasonably optimistic that we are going to get to a positive place on that. And the only thing I was going to mention was, if people aren't already aware, is that the LMCs do actually meet across North East London with the ICB, but we have meetings with their exec team. They've been ongoing for quite some time, but they have had a little bit of a change of focus recently. So we have been requesting that financial colleagues, so Henry Black attends those, and Joanna Moss, who is our link within the exec team at the ICB, who has the responsibility for primary care. and general practice services. So we meet with them regularly on a quarterly basis, and we are trying to get an understanding of the financial position of the ICB. We know that there are challenges. We know they're in a double lock financial position, which is not a nice place to be from a commissioning perspective. But you cannot save tens of millions of pounds, which is what they need to do as a system, without that having some form of impact, either directly or indirectly, upon general practice. So we need to stay close to them to understand what their financial recovery plans are. And I think we are starting that. I don't think we'd claim to say that we had full oversight or understanding of what those plans are now, I think, if we're being very honest. But we do have those links in now, and we are continuing that conversation because we need to be close to those decisions, even decisions that don't necessarily relate to general practice funding. The broader decisions in the system will have an impact, as I say, in one way or another to general practice. So we need to stay close to that. So yeah, they were the only bits that I was going to raise today. Apologies, we didn't do slides. I've not been organised enough to do that, but I will attempt to do that for next time, I promise. So they were the only things that I was going to raise, but more than happy to answer any questions or talk about any other issues if people wanted to raise them.
Thanks, Kate. I think Rima's got her hand up.
Yeah, thank you, Kate. Apologies, I've still got a cold, so I hope you can all hear me. So that's really helpful to kind of get an overview. Obviously, we know where LMC are involved in across the whole system.
Sorry, I've just lost your sound, Rima. I don't know if you just put yourself on mute.
Can you hear me now?
Yeah.
Sorry, I don't know how far I got. So yeah, really nice to hear. Obviously, there's lots of work that LMC are doing. I think I'm just mindful of that kind of duplication as well, and just making sure that we have kind of the right representation everywhere and that we're feeding that back. Obviously, you mentioned the primary care and secondary care interface, and yes, you might be aware of what's happening at North East London with the plans there, but we've also then got our local plans that that are happening, and that meeting yesterday was the outpatient meeting, but obviously then we've got our local interface meeting with our consultants and stuff, so which is planning. So we just have to make sure that there's no duplication and that we just get feedback from all the different meetings that various people are attending, and bringing that all together.
Completely agree, Rima. And as Tammy says, that's one of the things that we really need to focus on in that unified voice, to make sure that we aren't wasting resources that none of us have got doing the same job. Right, let's not all do the same things and duplicate, because none of us can afford that resource. Our most precious commodity is time, and we don't have enough of it. But also we need to be aligned in what we're saying. So when we are going to different things and we're divvying up our resource, let's make sure that we are aligned and unified in our voice. So yeah, couldn't agree more. And our plea to the ICB in relation to primary care, secondary care interface was, please let's not start with a blank piece of paper. Please let's look at what we've currently got and build on the good things that we have, rather than starting from scratch. So hopefully that is aligned with that as well. But you're right, we definitely need to link up, and that unified voice session once a month is definitely one way of doing that. And hopefully we can build relationships so we can catch up in between in different ways as well.
Great, thank you both. And sorry, Kate, for calling you Sarah. I don't know where we got that from.
I've been called far worse, don't worry.
Right, so next we've got Salma for our now update, and I think you're going to be talking about transitional funding.
Yep, that's correct. Hi everyone.
Hi, thanks.
Yeah, my name's Salma. I'm one of the senior transformation managers for primary care. Okay, so I'll just quickly do an overview of the transitional funding. I haven't done any slides. So you may recall around October, November time, we asked all the practices to fill in a practice improvement toolkit. And the purpose of the toolkit was for practices to identify their progress, issues and support needs to help deliver modern general practice and the North East London Access Recovery Plan. So far, we've had responses back from all the practices, apart from 2 practices. We're waiting on, we're following up with those practices. And the toolkit was a prerequisite for applying for the transitional funding. In terms of the feedback from the toolkit, we will be doing an update. either in the December transformation meeting or the January transformation meeting to give you an overview of the feedback that we've received from the toolkits. So for the transitional funding, so NEL ICB, we've received around 3.2 million, of which 1.6 million is available in 23-24 and 1.6 million available in 24-25. So the practices who have completed the toolkit can submit a proposal to the ICB outlining how they propose to use the funding in line with the national guidance. The funding can be used, for example, to pay for sessional GPs, support from experienced peers, or for additional sessions from current practice staff. And this could be clinical or non-clinical. The funding can be used to support the goals of the Access Recovery Plan. Practices can use the funding to support a broad range of activities across a number of categories. For instance, clearing the backlog of appointments before the launch of a new operating model, investing in better digital telephony, providing simpler online requests, faster navigation assessment and response. This could be by supporting staff to attend care navigation training or embedding a care navigation approach into practices, triage and appointment booking systems. Other examples could be creating local change management and process improvement capacity within the practice, participating in a national or a NEL-wide structured quality improvement offers. So these are just some of the examples that you could apply the funding for. So in terms of applications, the deadline for the applications is the 31st of December. Once we receive the applications, a panel within the ICB will go through the applications and approve. And once approved, or provide feedback if anything needs changing. Once approved, practices will be paid 50% of the income within the 23-24 financial year, and then the other 50% will be paid in 24-25. Where practices feel that they've already successfully transitioned to modern general practice, they will still be eligible to apply for the funding, but so they have to evidence what they've done, and they'll have to show in terms of what they will use the funding to further enhance what they've already done. So they could use it for a further evaluation of the work to enhance what they've already done. In those circumstances, we'll need to be assured of how the money has been spent in line with national guidance. So far, we've received 7 applications from Newham practices. So we've still got loads of practices still to do the applications. We are attending the Practice Managers Forum coming up, and we'll be doing like a question and answer session there for any practice managers that need support around filling in the form. And that was it from me. Happy to take any questions. Okay.
So thanks for that. Yeah, not necessarily a question, but just to reiterate some of the conversations that we've had with Alison and Will, certainly the central NEL team, because we did ask about uptake of this. Obviously, it's reasonable pot of money. Average is about 13,500, doesn't it, per practice nationally. I think across the whole of North East London, you'd had about 30 responses from practices, which is obviously massively low. But my understanding is that this funding is national and it needs to be spent this year or it disappears into the ether. So obviously, we're really keen to make sure that practices that want to engage with it do get the funding. And obviously, it does cross over reasonably heavily with some of the PCN work that's been taking place around access and things as well. So we did get some assurance from Alison that the actual form that practices need to complete is just a Word template, isn't it? And you are just looking for a few sentences. I think it was the way it was described to me, a few sentences that describe the themes of the work that you are doing around the access. So it's relatively light touch in approach. Is that correct? Because I think that's the message that we wanted to reiterate to practices. Obviously, the funding could potentially be lost if we don't claim it this year. And also that it is relatively light touch, and all practices will probably have had sight of their PCM plans around very similar topics. So obviously it's not for the LMC to advise how to complete those forms, but it is just a few sentences on things that are already potentially included within those PCM plans on similar subjects. So I just wanted to reiterate that. Obviously we'll be keeping in touch with the ICB closely about this because we don't want that money to be lost. So we will be having further conversations with them in the new year if the uptake continues to be low. But yeah, I did just want to add those things in. So sorry, Salma, not particular questions, but just thought I'd add to that.
No, absolutely. That's fantastic. Yeah, you're absolutely right, Kate. Yeah, we have across now the applications have been few, and we don't want to lose that funding. So if there's within the application, there are four boxes, and what we're requesting is that you fill in one of the boxes because the funding is small. It's not huge. If you can evidence that you want to do 2 different areas, then that's up to individual practices, but we're requesting you either fill in one box of 3 different areas that you want to focus on, and the 4th box is if you've already achieved modern general practice, and then the evidence to show that. But we're happy to take any questions from individual practice managers or GPs. If you need help with filling in the forms, then do reach out.
Thanks, Salma. And Kate, thanks for reiterating that the form is light touch. So I think here at this stage, I think practices should definitely get that form filled in and sent in. I've got one question from Asha from the Azad practice. She's asking, if we take up the universal offer of support, would we still be eligible for funding?
You would be, yeah.
Okay, great. Okay, so practices, if we can make sure, so whoever's here from their practice, just make sure that that form's been sent in. And I don't think we have any more questions for you, Salma. So thank you.
Thank you very much. Just one additional thing Layla's asked me to mention is around the EDEC submission for practices that haven't submitted. Just a reminder to submit the EDEC.
So just for practices, the deadline's been extended to the 15th, but obviously do get it sent in as soon as possible. Okay. Thanks, Salma.
Thank you. Bye.
Bye. Right. Claire. So we've got Claire Davidson that's going to be talking about our Newham winter planning, and you've got about 10 minutes, Claire, and just quickly, Subir.
I just wanted to tell you regarding the EDEC, whatever you declare you have, you must have the evidence, because EDEC is highly scrutinized by secrecy. So don't say anything that you don't have, you cannot prove later on. So be careful what boxes you're ticking.
Yeah, thanks, Subir. Claire?
Yeah, great. Thanks, Alpana. I think there were some slides. I don't know if staff can just bring them up just to sort of focus. Am I whispering? Yeah, there we go. Okay, next slide. So, so thanks for inviting me. I'm chair of the New Emergent Care Working Group, and I just thought I'd sort of put this here because I think there is a little bit of muddiness about who's responsible for what. So the New Emergent Care Working Group reports into the NEL Urgent and Emergency Care Programme, as well as the Newham Healthcare Partnership. So we have 4 working groups. You sort of think about the pressures at the front door, then there's the work within ED, trying to prevent admission, and then trying to speed up discharging to help the flow through the hospital. And now there's a new group called the Virtual Ward Subgroup. And some of you might be aware that there's been a nominal virtual ward started in Newham, run by the Acute Trust. And they generally have about 6 or 7 patients at one time, but it needs to increase to about 20. So that's just the overall structure. So if you go to the next slide, the decision making around funding and investing in winter planning is really done from North East London because they're the people who receive all the funds. And the New Emergent Care Working Group We talk about the priorities within all the various services, but then it's the commissioners that decide how those funds are allocated. And so the aim of the winter plan is to, as you can see here, keep people well at home so they don't hit the urgent care services, make sure there's lots of same-day urgent care to try and keep people treated on the day quickly so that they don't have to go into hospital, trying to reduce the congestion within A&E by various ways, but including same-day emergency care, which some of you might have seen the poster, which is at the end of the presentation. And then there's a lot of work being done about the flow of patients through the hospital. I'll show you some figures later. Apologies for why now? And so that is really about making sure there's enough social care capacity to take patients back into the community, as well as the therapies to support them within that, as well as an effective team working across the hospital, the community services and the borough social care to facilitate that. That doesn't really feel as though it's our bag, but just so you understand that if the hospital gets really congested, then A&E gets really congested and the whole thing starts backing up. So if we go to the next slide. So this is some areas of care that are already in place. So there's the proactive population health, there's some alternative care pathways, and there's flow optimization. So that's just thinking about the whole urgent care system. So as you know, the PCNs are working hard doing the COVID and flu boosters. There's some A&E work with asthma, trying to get patients treated and then followed up in primary care as soon as they can the following day or day after. As you know, we have NHC providing the single point of access and providing extra unscheduled primary care appointments, which is very helpful for UTC and 111. And there's also the pharmacy work. So if there are any pharmacists on the call, clearly there's some primary care work going on through the pharmacies. So that's what's going on already. We heard this year that there wasn't any money. Everybody's saying North East London's completely strapped and overspent. We didn't think there was going to be any winter funding. And often winter funding, inevitably, they say, here's some funding, and people say, let's get some staff. But since COVID, everybody knows recruitment has been really, really challenging. And so by the time you try and recruit staff, you're often through winter. And so one of the messages that we've been saying in the Urgent Care Working Group is, could providers think about how to use their staff more effectively, scheduling year end of annual leave, trying to think of being a little bit over capacity so that you encourage people to have more leave in the summer. And so in the winter, that little bit of extra capacity bolsters your services, because it is very, very difficult at the moment. And there are some investments that have been made, and these services are finding it really difficult to recruit, as primary care is finding it difficult to get manpower. So if you go to the next slide. So about 3 weeks ago, so in September, the Urgent Care Working Group, the various providers around the table, and from primary care, we have Hamida from the GP Co-op, and we have Karen and Paula from NHC, and obviously myself as chair, but I have to be neutral. So we're all told there was no funding, but we should get our thoughts together to prioritise, if there was funding, how could it be used and invested? And so as you can see on the left-hand side, there's the general principles about the whole of the urgent care system. And on the right-hand side, there were the potential investments that could be made. And so then about 3 weeks ago, we were told there was some funding, maybe 3 or 4 weeks ago. So the various providers are making investments, and that's on the right-hand side of the slide. So there's been some winter comms developed both by North East London and by Newham, and that's both for patients and for health professionals. There's some work going on because one of the main reasons, of one of the top 5 clinical reasons for A&E attendance is UTIs, particularly for the elderly. So there's some support going around prevention of that. We recognise that the under 5s are very high users of UTC, 111, urgent care, primary care. And so we found in the evenings there was a real need there. And we have got some primary care capacity divert services, but it was felt that a lot of this was just basic support for parents. And so the health visiting service has been extended between 5 and 10 p.m. We did some analysis of the 111 service that NHC is providing. We found that 40% of the workload was respiratory, and that was in October. And so that really bolstered our application to get a respiratory hub which has been funded, and I think it'll be starting the first week of January. There's also been the add-on service, the UTC bypass and 111 bypass service that's provided in Glen Road and Essex Lodge. And so we really want to work on maximising that utilisation because it isn't fully utilised. So we're working very closely with the UTC. And then also there's been the issue about the wound care, which I'm sure many people on the meeting are aware of. And so there's a gap until April for wound care. So there's a small amount of funding that's developed an alternative care pathway for UTC to divert wound care because it's such a time-consuming process for them to use when they're under pressure. And something that we all have contact with in primary care, and we were talking about earlier, the interface between primary and secondary care. In urgent care, I think there's a real issue sometimes of getting the patient to the right service most quickly. And in theory, that should be going through the same day emergency care pathways. I'm sure you and I have all experienced how they don't work effectively. I had an incident this week, which is a learning event. And I think if anybody has a situation where they're having trouble getting their patient into care quickly, if they could let me know, then we can work on the interface. And I know that Rima and LMC have both mentioned that earlier in the meeting today. For me, we're having real problems with recruitment. There's an issue with capacity. It is really about making sure that when we're working, we can work as speedily and as effectively as possible. I think to have a GP on the phone for an hour, going around a service, trying to get a patient landed is completely hopeless. It's a waste of everybody's time. And so the more we can have examples of where the pathways aren't working, the more we can work on these interface issues with our partners to try and smooth things out. So Max, maybe if we talk at the end. And then just to say there's some other investments being made in the enablement services and in the discharge pathways. If we go to the next slide, I think I've just got some figures. Yeah, so just to give you an idea of the figures for Newham, 111 calls, there are about 9,000 calls a month, and 50% of them are termed primary care dispositions, which will include some dentistry and pharmacy, etc. If you look at the GP workload, about 1,600 are placed in the GP Connect appointments, 1,400 are passed on to GP out of hours, and about 1,300 are coming through the access hubs. There has been a recent expansion to that service. UTC gets about 150 to 200 cases a day. We have 48 UTC divert slots, so they aren't fully utilised, so that's an opportunity. But we have 30, as of yesterday morning, they had 30 patients waiting in ED for a bed. They had 58 inpatients with a length of stay more than 3 weeks, and 29 of whom medically optimised, so didn't need to be there. And that's on a bed base of 240. So that just gives you the idea about the extreme congestion within the system at the moment. So, so they are trying to work on improving the outflow from the hospital, but equally, I think it's about trying to think how we can use ED most effectively so that patients don't just end up there as the last port of call, which I know happens a lot, and it's a fact of life. But the more we can learn from different clinical cases, I think it'd be really useful for those interface discussions which Rima mentioned. Next slide. So these are just some of the resources that are being sent out to patients in the first box, or sorry, on the right-hand side there. So if you want to put those on your websites, they might be helpful, or fling them around by text. So they're one of them, they're from Newham and from North East London. And then the next slide is a summary of the various urgent care services, such as the mental health crisis line. And then, so if any of these systems don't work, could you please let us know so we can raise them and smooth out the clinical pathways? And then the next slide is the SDEC poster. And again, we've been reassured by Newham Hospital that these systems and pathways are working. My experience this week was they weren't. So We need examples. You know, as a clinician, I just find that talking about cases is the way to learn medicine. And I think talking about clinical cases is the way to improve pathways. There's no point sitting around in big committee meetings, everybody chewing the fat. Give us some examples. Let's break it down and see where the issues are, you know, in the real world today. Why didn't that work? So any examples, give me the information. Thanks very much. So Wax, I think yours was the first query, if you're still here.
Yeah, I've got three. I think I've probably got three, Claire. Firstly, what's all of this? So you've just put on, there's about 20 different things, that numbers and emails and contacts and all of that kind of stuff. That's cool, that's fine. But for patients, that's an absolute nightmare. Our service in Newham is fractured, okay? Please, 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 my request to yourself who are working with the commissioners, and I've said this to Will, and I've said this to Layla, and I've said this to Sarah, and I've said this to Jay, and I've said it to Mark, and I said it to Kate. Please, 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 can we move forward with a 24/7 pathway for Newham? I'm conscious of all the sensitivities around that, but we absolutely need to have lack of that means going against the PCN grain potentially, okay? But until then, we are not going to be able to solve this problem. Number two, I've just had an email in at 10:41 that LAS are completely strapped. I spoke to LAS myself on Monday. They had 6,111 calls. 6,000. It's just phenomenal. And I don't know where they put everybody, but they managed to. So everybody's being drafted in from everywhere. Yeah, that's really to make everybody aware. Please do check your email, but anything that we can do to support LAS in any way, shape or form, please, please, please do have a think back at the ranches. Sure. Number three, winter monies. Proportionally, Newham's a massive borough. You've just outlined and articulated really nicely the numbers we are sinking in Newham. Why did we not receive like sort of list-based or population-based quotas for winter monies? Why was ours the same as City and Hackney and Tower Hamlets? That doesn't need to be answered now, but I'm a bit disappointed about that. We are double any other borough in size, and we have a massive transient population. And the final thing, Claire, was the strikes. So none of what are we doing to take into account that there's going to be 3 rounds of strikes? Colleagues are allowed to strike. I believe in unions and stuff like that. But for everybody who's not striking, I'm going to be honest with you, it's going to be an absolute disaster zone. No money has come back to practice to put on extra appointments or anything out of that winter resource or anything like that. So I'm just a bit sort of like confused as to if everybody's striking, what's going to be happening with that winter money on those days. That's one thing, and I could think of 100 other things as well. I know there's a lot there, Claire, but this is a really, really, really horrible time, and I've heard it mentioned on this call for about 10 times in the last hour. But yeah, we need our commissioners and our ICB board to really, really, really get to grips with this and sort things out for patients.
So Wax, just to start off with, as far as the 24/7 offer, I am apprehensive because I feel that, well, I was on a conference. I went from my study day to an urgent and emergency care conference. There were some really good examples of where there were some systems in the country that had got it sorted. They were pan-borough systems, and they were pan-borough systems where the providers were integrating, but largely primary care led actually. But primary care was integrated with 111, and it was integrated with UTC, and it was integrated with the access hubs, and it was integrated with the out of hours. And by getting that sort of, as you say, that 24/7 join up, and it is difficult because that does go against the grain of the PCN. It does, the PCN modelling. It does feel as though, well, first of all, there's a lot of confusion about who's contracting what. And so certainly in the urgent care working group, we don't see ourselves as contracting urgent emergency care. We have managed to divert some funding into the expanding the access hubs. But there is really confusion here about, for me, the 24/7 offer is very much a primary care commission service, not an urgent care commission service, but I think that's very muddy water. And I don't think there's clarity or uniformity of opinion across Newham and North East London on that. But I agree with you. I think to have a pan-borough service is the only way to go as far as really getting those pathways streamlined and effective. LAS, you know, we could easily have a conversation about whether we could flip some of our UTC appointments over into 111 if 111's struggling, because UTC certainly doesn't use them all the time. The winter monies is a challenge that was out of our hands. That was in North East London. So I do think there needs to be a bit of a double act between the people at Newham level and the people at North East London level. Because I think there are a lot of decisions that have been made at North East London level as far as the allocations of funds. And we have a weekly huddle with all of the partners once a week because of the winter pressures. And last week, this coming week, we're going to be talking about the strikes. And it is an issue, Wax. I know it creates a whole lot of pressure in primary care. And certainly I agree with you that in principle, the strikes is the right thing to do, but the impacts on the service, on waiting times, on general practice, on patients has been pretty adverse. Tammy.
Sounds like you agree with all of it. To be honest. Guys, so sorry that it's going to be so tough. Just Claire, we really could do with some appointments back. When they do this winter stuff, we really could do with some support to have some more appointments back.
Okay.
And in terms of the same day access, Claire, we need the commissioners to urgently look at any kind of duplication that's happening in the system. We've got 25 million providers with this duplication that we need to address. That money needs to be invested back into primary care to address the challenge that we're facing.
I'll raise it.
Thank you, Claire. Thanks, Claire. Thanks.
Okay. Tammy.
So Claire, that 1 hour that you spent on the phone trying to get through to someone back and forth is kind of the reality of day to day. But the other thing that concerned me, and I did escalate it, was that we're using mobile phone numbers here and you can't get through to them in the hospital. There's just a blank zone. So I think that, you know, with all of that we've got to get the IT right across the system. We cannot be expected to be, you know, sitting trying to get, you know, this mobile's not connecting, and then you go through a switchboard. And so, you know, the number of mobile numbers on our, you know, on the information is very worrying. I think the other thing is around the 111. So we had an example of a please sort out within 1 hour a change on a medical certificate that was booked into one of the 111 slots. So we have capacity, you know, we're ring fencing that for it to be wasted. It's just galling when we know that there are patients who are then walking in and you've still got this sort of cohort to deal with. And then they're building up this expectation that we're going to, you know, respond in an hour. So I think that really needs to go back. We need to take control of this. And I think the other issue here is that we know that our patients find it really difficult to navigate the system. So if it is confusing and difficult for us, then God, it's really awful for them as well. But just about the respiratory hub, I know we're going to then be waiting until January, but I think it's really important for us to understand how we're going to utilise that. So will there be, what's the eligibility criteria? You know, where are we thinking of housing that? You know, sort of just the logistics of referring in. Is that going to be something that we as GPs send in? Is it something that, you know, is only going to come via the single point of access? I think it'd be really helpful for us to plan a little bit from the primary care perspective about how we're going to utilise that effectively.
Thanks, Tammy. Yeah, that's really helpful because we will be bottoming that out. And so certainly if we could discuss that with you, that would be great. I don't know if Paula or Karen want to talk about the 111, because I think that will be changing in January as well, won't it? Because I know so many practices are saying they're not happy with the way the appointments are being utilised.
Yeah, so the issue you referenced, Tammy, about the 1 hour appointment being completely inappropriate use. I'd like to think that the process from January will make that more, well, improve it. I don't want to guarantee it. These things will never happen, but the process after January will be that the appointments will go through the clinical assessment service, and so where possible, those appointments will be dealt with by a telephone consult and or referred into, you know, pharmacy or other routes. And then only the appointments that need face-to-face on the day in that sort of urgent way will be booked into the GP practices or into the enhanced. Just on your ask around the respiratory hubs, I know that some of the planning's underway, so we'll just make sure we reach out to colleagues to try and make sure that wherever possible, those that want to be involved are involved in helping make sure that the arrangements work to the best.
Okay, so that information, all those useful, very useful mobile numbers, Tammy, will be circulated with them.
Yeah, we'll make sure all the slides and links and everything are all in the
I'll pass that message
distributed
on as well.
information.
So thanks for the feedback, and any more, anytime, it would be really, really gratefully received.
Thanks, Claire.
I'll put
And
my email.
I was about to say, you're happy for us to email you. I know that.
Yeah,
So thanks. Right, so that's the end of our meeting today. Thanks to everybody that's come and joined us. Thanks to all the speakers. And I would like to wish everybody a very Merry Christmas and a Happy New Year. I know we've got a few days where general practice is going to be closed. But I think we're going to be making up for that when we come back, where we're helping with the strikes. So please, everybody, try and get some rest in those few days off and try and spend time with family and friends. And as I mentioned before, if your checkup with your GP, with your own GP is due, please do take this chance to book that in. Okay, take care, everybody, and have a good rest of the day. Bye.
So far.
Yes, and wear your Christmas jumpers.
Yes, I forgot to wear mine. Merry
I've
Christmas,
got mine
everyone.
on.
Bye.